Slides. My topic today is going to be suicide screening in neurodivergent population and our experience at Kennedy Krieger. I want to start this talk reminding you actually to share with you what brought me to complete my CAP fellowship at Hopkins, and it was the work of this man, Dr. Leo Kanner. He is widely regarded as the father of child psychiatry in the United States. His paper describing autism as a neurodevelopmental disorder in 1943 is seminal. So for any of our trainees, if you have not read that paper, you need to go look for it and read it. He describes, the first description of autism as a disorder. Kanner worked at the Harriet Lane Home for Invalid Children at Johns Hopkins. In 1930, when he joined Johns Hopkins, right after he came, Professors Al Mayer, who was at that time the director of psychiatry, and Dr. Edward Spark, director of pediatrics, selected him to develop our nation's first child psychiatry service in pediatric hospital. He served as a child, I'm so sorry. He served as a division chief until his retirement and in 1959. Time just flies. That is why the Hopkins Division of Child and Adolescent Psychiatry Fellows are called the Kanner Fellows. I want to be respectful of this audience, and I want to make sure that I'm clear on the terminology I am using and why. There's a movement to define neurodivergence with asking for a change from a medical model of disorder to a social model of neurodivergence as a difference in neural connections that should be considered a variant of the normal. The Merritt Dictionary defines neurodivergence as someone having or relating to a disorder or condition that impacts the way the brain processes information. This is not a statement or an opinion of any kind. As a physician, I am going to be using the medical definition of the Merritt Dictionary that coincides with the definition of the DSM-5 of neurodiversity as a disorder. This is an overview of what I want to talk to you today, and it's what is a neurodevelopmental disorder, and I'm going to be using NDD because you're going to hear how I pronounce neurodevelopmental disorder, and even it annoys me, so I'm going to use NDD. The epidemiology of psychiatric comorbidities in NDD, the mental health crisis and how the suicide screening came to be, our research efforts and our efforts in workforce development in addressing the needs of individuals with NDD and mental health difficulties. Now, DSM-5 replaced the DSM-4 section of disorders usually first diagnosed in infancy, childhood, or adolescence with a new section called neurodevelopmental disorders. The new DSM-5 classification includes the two new categories of brain dysfunction: neurodevelopmental disorders with onset in the developmental period and major neurocognitive disorders with onset in later life. In the adult psychiatry, you of course will see most commonly the second part. Again, I'm going to be using the NDD throughout this talk, as you have heard my pronunciation of it. When I speak fast, it gets iffy. So to be able to understand what NDD is and what it is not. Now, the presence does not necessarily imply intellectual disability. So you can have a neurodevelopmental disorder and be cognitively average. Oops. It's missing the cursor. Oh, sorry. I'm so sorry. I'm looking for the mouse, which I don't see oh, there you go. It showed up. Oh, good. It showed up. There you go. So intellectual disability is a disorder of reasoning and judgment, and that definition has relied excessively on an IQ cutoff. As such, individuals with NDD have been discounted as unable to understand concepts or respond questions by themselves. Interestingly enough, when I use dual diagnosis, it does not mean the same dual diagnosis that you're thinking about. Dual diagnosis in the neurodevelopmental world means intellectual disability and something else, and a psychiatric comorbidity, different from the adult world where you usually hear psychiatric disorder and sometimes substance abuse. This is a different dual diagnosis. Now, the DSM-5 defines neurodevelopmental disorders as a group of conditions with onset in the developmental period that induce deficits that produce impairment of functioning in different areas. Now, the DSM-5 also includes a specifier that is an association with a known genetic condition or an environmental factor. My patient, and I forgot to mention that, he has a de novo mutation of unknown significance, so it was not really relevant to bring up. These are the categories of neurodevelopmental disorders, and you will often hear intellectual disability and autistic disorder, but there's really much more than just that. Particularly relevant are communication disorders and motor disorders, where are usually lost in the shuffle. When people cannot speak, they're often dismissed. Just think about the stereotypes when deaf people and people who do not have English as their first language, people talk louder at us just because they think we cannot understand. Now, psychiatric disorders account for 14% of the global burden of disease, as well as 2/4 of all disabilities. The prevalence of mental health disorders in children and adolescents with NDD ranges from 30 to 60% depending on the population study, meaning individuals with ID and ASD can have a mental health problem just like anybody else and should be addressed as such. Psychiatric disorders occur at least 3 times more often in children and adolescents with intellectual disability than in children with typical development. Now, this gets trickier because the DSM-5 does not allow for adaptations for diagnosis in the context of an NDD. How do you differentiate behavior versus a mental health symptom? How do you know if somebody is manic or depressed or psychotic if they cannot tell you? There are some initial efforts like the IDDSM. I don't know if anybody has heard of about that book. They're in the 2nd edition. It's a manual that considers intellectual disability in a mental health diagnosis. But the reality is that, like I said before, intellectual disability is only part of it. It's not super helpful, as not everybody has intellectual disability and not everybody can speak. And that manual still assumes people can speak and openly communicate. Now, this slide, I have to mention this story because if I've written John Campbell, and he's my boss, and he's going to say, how come you didn't mention it? So it's there. But I think it is a great example on the opportunity to survey the population to be able to get a better prevalence. Now, again, trainees, if you have not read this is historical. This is 1970. And, it just reminds us how, on the reality that in the current times, we do not do a good job in healthcare surveying our population. So many data from studies come from Medicaid, which picks up available diagnosis, from hospitals who also pick up available diagnosis or chief complaint, but leave out secondary diagnosis. Like a great example of data that I would want to know is suicidal ideation and autism. And when you try to extract the data, you get one or the other. And if you get both, it's a miracle because most people just think on, why are you here? And click one. So, it's very, person dependent. Now, why is this so important to me? So, I don't have to tell you too much about suicide in general. You know this, you live this, and we all do it on an everyday basis. But you might not have heard too much about suicide in youth. Now, it is interesting to learn that 80% of children who died by suicide see their pediatrician or another healthcare provider or are seen in the emergency room in the year prior to their death. 38% had contact with the healthcare system within 4 weeks of their death. 80% of pediatricians have reported that at least one patient that died by suicide. 48% of pediatricians reported that a patient had an attempt or died by suicide in the last year. African American children ages 10 to 15 are double as likely to die from suicide than peers, and LGBTQ youth are 5 times as likely to die by suicide than peers. Now, I'm sure you have seen, the latest CDC regarding to suicide. It is the second leading cause of death in children ages 10 to 14. The second. And in ages 15 to 19 is the third. Now, why are we not addressing this? And, we have started. Oops. We have identified some of the risk factors for youth suicide. And I was trying to precisely because we are in the NDD, in the medical model concept, we see them in the clinic with medical diagnosis. So I tried to pick one that we see most often. And then I started, putting them in red, and I started, it's all of them. So, it is something that we were not thinking enough, and now luckily we are, because neurodevelopmental disorders does not exempt you from suicidal ideation. They are present in 42% of the population and 11 to 50% on autistic individuals of all ages. Children with intellectual disabilities have 3 to 5 times higher risk of psychiatric comorbidities compared to their peers. 11% of children with autistic disorder have suicidal thoughts and behaviors along with frequent depression and PTSD. And you wonder how much this is related to their social interactions and victimization. Autistic adults who attempted suicide compared to those without ASD and were hospitalized were more likely to have adjustment disorder, have poor interpersonal relationships, attempt with more lethal means, and live alone. As you can see here, youth with neurological, developmental, and behavioral disorders have known suicide factors, but despite increased risk, youth with NDD are often excluded from screening due to communication challenges, under-recognition, or comorbid psychiatric disorders, and the absence of a validated screening tool for this population. Now, Joint Commission stuff, don't like it. However, this was maybe a good thing. 2016, they came up with the Sentinel event alert with the goal of detecting and treating suicide in all settings. The directive was literally screen all patients for suicidal ideation using a brief, standardized, evidence-based screening tool. In our Kennedy-Krieger setting, there was a multidisciplinary task convened to determine what was the best approach, and it included medicine, including, of course, child psychiatry, social work, nursing, psychology, and administration. And with input from our friends from the School of Public Health and experts on suicide prevention, thank you, Holly, all the education was staffed and implemented the administration of our screening tool. We chose to have the ASQ. Why? Because it had been used in the ER at Johns Hopkins. The ASQ is pediatric specific and it's non-proprietary. So this tool checked all the boxes that we needed. These often confuse pediatricians because there's another ASQ scale that is called Ages and Stages Questionnaire. Now, in our medical clinics at Kennedy-Krieger, all patients are triaged by nursing. The nurses administer the ASQ. Patients 16 and over are asked to complete independently and without the parent present. Sometimes it happens, sometimes it doesn't. When a yes to questions 1 to 4 and a 5, it's a positive acute risk. Yes to 1 to 4 and no to 5 or no response is a non-acute positive, non-imminent risk, but requires further evaluation. Then a brief suicide safety assessment is applied by the clinician seeing the patient, in this case, the physician. Now, very interesting stuff came up when we started screening. And the first round of implementation was what is called in these medical clinics. The first round excluded psychiatry because we were already screening for SI in every visit. That changed later on. But this first 6-month study period, we had 5,260 eligible visits, 3,854 screenings. A lot of them declined 90% because of the parent decline. Most significant was the overall positive rate of 6.8 on the ASQ in our special population of children ages 8 to 17 across all the medical clinics during this period. The highest rate was in our autism program, where 12% of the children screened positive in the ASQ. Again, the initial effort did not include psychiatry nor any mental health clinics. This is the BSSA. If you've never seen it, it's just to give a guidance on people to do a safety assessment when they're not familiar on how to do it, and it's a standardized version. And these are all available in the NIMH website. One interesting thing that we noticed is the parents of children with cognitive impairment were more likely to decline the screening. These are the reasons listed for declining. It's very interesting that if you read them, some of them, it's parent choice of not discussing it. Oops. These are the responses these are the questions. Again, a reminder that do not treat every young person who has a thought about suicide as an emergency. There's a clinical pathway that is a guide to avoid unnecessary interventions and emergency room visits. Now, the outcome of the screenings showed on 261 total positive screenings, 14 of them were acute. These children were referred to a higher level of care, these 14 children. Now, 7 of these 14 who screened positive for acute ideation were verified as acutely suicidal on the clinical exam and completion of the BSSA. 2 of the 7 were referred to the emergency department, 3 went to an intensive day treatment program, and 2 were admitted to the inpatient psychiatry. And again, not every positive ASQ means it is an emergency or needs a hospitalization. Now, the initial lessons we had is that children with NDD have a risk for suicidal thoughts and behaviors at rates comparable to typically developing youth. Some clinics had higher rates, which was concerning, but we don't know why. Are we asking the questions correctly? And is the ASQ validated for NDD population? It's not. So these open up the avenue to have a collaboration with our friends from Nationwide and NIMH. We became part of a multi-site study with a grant funded for 2 years for the American Foundation for Suicide Prevention, with the goal to establish the clinical correlates and validity of screening in children with ASD and other NDD presence. The recruitment goal was 270 subjects. This is our team for the validation study of ASQ-AD, which I want to make a point of specifying the diversity of our collaborators. These are developmental pediatricians, psychology, PM&R, very different perspectives in clinical practice, as well as approach on suicidal ideations and response in clinical settings, meaning they all get scared. We recruited from 3 clinics: GASI, which is the Center for Autism, DBH, which is Developmental Behavioral Health, that's where I live, and the Phelps Clinic, which is the Cerebral Palsy Clinic. The ages we recruited were 8 to 17, and the patients were recruited from our triage process by the nurses that then passed on the information to the research assistants to contact them. Of course, if positive ASQ on the day of the visit, we follow a clinical path and a referral to research. If not positive, then a referral to research, as safety is always the priority. The research assistants then gave the candidate screening item difference from the standard ASQ along with other measures. Then, if necessary, a BSSA was performed. We just completed the recruitment last month, and our total number was 272. 235 are from Kennedy Krieger, and Nationwide only 45, so we had to brag about that. The data is currently being analyzed by NIMH collaborators, we hope. Now, our initial results brought up more questions, particularly if research could be actually effectively done by telehealth, and the big question that everybody has: do these children actually have an understanding of the concept of death and the permanence of it? So our team presented this preliminary data on death understanding in AISR in Barcelona, where most youth with NDD seem to understand the finality of death. However, a considerable portion of them were either unfamiliar with or did not understand the meaning of the word suicide. More older children understood the meaning of suicide compared to younger children, and we speculated, what is that? People use other words to describe suicide is the most reasonable answer, but that's just a speculation in the absence of data. But we're working on that. A little bit about this topic is that youth with ASD and ID performed similarly to youth without in providing an accurate definition of suicide. And although this is a great start, we are well aware of the limitations. We did not have a control group. Most of the kids had ADHD as a primary diagnosis, and we have very few kids in the range of 8 and 9 years old with ASD. So there's a lot more to do there. Now, a comparative sample of typically development children should be surveyed to further understand the level of this population. And it is important that suicide prevention strategies be age-based and tailored specifically for effective communicating with neurodiverse populations. So these, again, brought more questions and the next steps, which are adaptive interventions. So we are collaborating right now in a 5-year multi-site study comparing outcomes between 2 safety planning strategies for young people. Now, initially, it was 15 to 24 with ASD and suicidal ideation. Now we're to 12 to 24 to facilitate the recruitment. We are 4 health systems. The sample goal is 1,500 autistic youth. 150 clinicians are trained on these interventions, and the plan is to deliver them as standard of care. Then the patients get recruited, or they offer recruitment at time of offering the tailored safety plan. The patient subjects are randomized between 2 groups: the safety planning intervention for ASD we call it the SPI, and the SPI Plus. The SPI Plus, it includes a text follow-up to improve connectedness with the medical support. Now, any autistic youth with a positive ASQ who does not require continuous monitoring is offered the recruitment. Clinicians randomly assigned to implement either one or the other, and we are now recruiting. And what else can we do in the meantime? We have a lot of data from this screening, and what are we going to do with them? So next step was we got a work group, Suicide Risk Screening and Prevention Research Work Group, aka the SWAG. That took us forever. That was so funny. Again, very diverse group: pediatrics, developmental pediatricians, psychology, neuropsychology, neurology, and most importantly, psychiatry. We have disseminated this information across disciplines and audiences. Most relevant to me is precisely those outside of our mental health scope, because they are the ones that are more afraid, in my view, to ask the S question. Several papers have been published on this. We have a couple of manuscripts pending in transition, and we hope to continue to do this. Now, I have some key takeaways, but I hope to speak one more minute. Jimmy, you caught me when you think I need to shut up. But individuals with NDD do have a risk for suicidal thoughts and behaviors, and rates comparable to typically developing youth, number one. Number two, NDD does not exclude you from having a psychiatric disorder, and not everything is behavior. That's the worst thing you can tell me. Research team members do not have to be your same specialty. And this particular message is very relevant to everybody that is not in the child train. None of the adult training programs list neurodevelopmental disorder as part of their curriculum, except palliative care. There are 130 specialties and subspecialties accredited by ACGME that use best practices. The requirements only have a list of common program requirements, and the didactic topics are pretty much open and flexible to plan them. Only a handful of programs that are pediatrics or palliative care involve education in neurodevelopmental disorders. Specialists in mental health in NDD are scarce, almost non-existent, particularly for adults. So residents, junior faculty, if you haven't found your niche, this is it. There's, join us in the NDD world. There's so much to do there. And if you have one more second, I just want to share with you what we are. Maybe we have never met because my home is 3 blocks away. This is where my home is. We have that little yellow part. It's our program, Developmental Behavioral Health. It's part of the Kennedy Krieger Bigger Mental Health Services. This is our team. We have 37 psychiatrists and 12 fellows. We have psychologists, social workers, nursing. This is a medical patient-centered operation that delivers evidence-based treatment in an interdisciplinary manner. We have nursing to support our physicians. You heard me about triage. They are the exoskeleton of our medical operation, because our psychiatrists are all over the place. They have clinic, but they are in 12 South, the ER, day hospital, CMHC, Yard 56. It's like herding chickens. So without them, we really cannot do this. We also have a neurologist in our staff. This is our leadership at DBH. Bunch people. Most important thing, we work very hard in training the next generation on subspecialty care. We have a neurodevelopmental fellowship for somebody that is already a child psychiatrist and wants to specialize in this population. It is co-led by Dr. Roma Baza and Dr. Aaron Hupman. And we host the Canner Fellows, child psychiatry fellows, who spend time with us during their 2 years of training. And not to brag, but the last graduating class, the whole 6 of them, loved us so much that they stay. We host residents and all varieties of disciplines, including child neurology, pediatrics, psychiatry, and of course, medical students. We have psychology interns, externs, and postdocs. And our newest thing is that we develop a social work psychotherapy postgraduate fellowship so they can learn evidence-based psychotherapy and have exposure to individuals with NDD, which is a population that is more often excluded from this service. These are our trainees, number of people we serve, and notice here, more than 1,000 are adults. We need you. Therapy expertise, therapy models. We serve Maryland. Lots of presentations. We rock the ACAP 2024. Lots of publications happening. We do also fun stuff besides taking care of patients. Look at the website, Chill Out Mind. We do Out of Darkness Wall in collaboration with others that are present here, Special Olympics, all kinds of things. So we'll go back to the key takeaways. We're here. Anybody that wants to do a rotation with us, we will be happy to host you. Thank you very much.
Thank you, Dr. Lopez-Arvizu. What a great array of projects, research projects that you're engaged in trying to get a handle on this important issue. You talked about about some of the questions around how screening works in a population that may not understand some of the concepts as well as other people, which makes me think, from the perspective of the behavior itself, are there any good studies that make clear whether people with neurodevelopmental disability have a higher or lower suicide rate compared to kids who are?
Yes, so one of the issues is that individuals with autistic disorder, yes, higher than the general population. However, the coding is difficult to extract the data because most people code just one diagnosis. So I cannot know if they had autistic disorder and something else, or if only the suicide event or self-injurious behavior was noted and nothing else. So the data is very iffy.
The data is clear that kids with autism have a higher suicide rate than kids
absolutely.
without
Yes.
autism. Okay.
Yes.
Okay. That's helpful. Thanks. Other folks have questions? No?
That's great.
Well, I'll keep going. Dr. Taylor.
Yeah, I know in autism there's a big gender disparity. I'm wondering whether rates of other psychiatric disorders or suicidality differ among men and boys with autism compared to women and girls.
Yes, I think it's boys. Boys, that the same thing applies. I think I have the risk slide, and it's very similar to the general population. White males have a higher risk. So yes, that's the same.
That surprises me because one explanation I've heard of the gender difference is that, girls who get diagnosed with autism, they have sort of a higher loading towards severity of the syndrome, and I don't know if that. So I guess my thought, what you're saying surprises me based on.
No, I think even the diagnosis of autism at this time, the rates are a little bit complicated. We have seen this significant increase that I've been doing this for 18 years, and I think I can be very good at diagnosing autism, and I have seen individuals diagnosed with autism that I don't think they are the true classical autism. I think that during the change, actually my patient, he was diagnosed with PDD, and then he got lost in the shuffle and then re-diagnosed with autism because then he fulfilled criteria. But there is, in my personal opinion, sometimes diagnoses of autism that are not fulfilling the criteria of the DSM-5 as it was supposed to be.
Sure. Other folks? Let me ask: Are there things you've learned in the course of doing this study so far, or just in other aspects of your experience? Are there things you've learned about ways in which suicidal thinking and behavior differ among kids with neurodevelopmental disability as compared to neurotypical kids?
I think they're very similar. They're just presented with different situations. So, like in the example of my patient, he, every time that he has a social interaction that doesn't work and he falls apart, you might learn from it, and then it's not going to happen again. But he doesn't. So it's like Groundhog Day. He has experienced the same situation 20 times and goes back to again being despondent because he's doing the same thing expecting a different result. So those kinds of situations we see more often. Many other times there are actions or behaviors that are self-injurious without necessarily being a planned suicide attempt, but it is an impulsive reaction to an emotional dysregulation of frustration, very commonly with communication.
Okay, thanks. Dr. Nestat.
I think they are less likely because it depends how you ask. So that's one of the things that we have been talking about. Are we asking the right questions? And we see that parents often don't want you to ask because you're going to plant the idea, right? So one of the things about the validation study is that there's a distraction task to be able to see if this is something that really impacts. And the preliminary data seems to think that really it doesn't matter. They do not get planted the idea. It's more the fear, just like I said, it's the S word. They don't want to ask. And then you want to believe that it doesn't exist just because you don't mention it. Now, a lot of kids do not know the word suicide because people don't use it. It's like a bad word. They talk about kill yourself, about dying. So are we asking the right question? I'm not sure.
Right. Interesting.
And the reality is that, you saw how long it took. I'm like, oh my God. But it takes a long time. It seems such a very easy task, but it takes a long time for somebody to answer and process the question and then process the answer and then tells you the answer. And sometimes it's not what you ask. So you definitely have to pay an extra effort when you do these kinds of assessments. That's why the ASQ is done by our nurses, but the BSSA is done by me. No, I think it's because people don't think it's going to happen. Because, they just assume they're not going to do it. So people don't ask. I think that's what it is. People don't ask. I mean, the implementation of this screening process, oh my goodness, it was like everybody was in panic. Like, I don't want to ask because what if, you ask and let's see what they answer. So they were really, really resistant, in all the medical clinics, like the non-mental health people, to do this. Now we do it across the board in all what they call therapies, OT, PT, everybody does it. And we have a planned response. We actually have, for the mental health people, we know how to do with this, but for the people that are non-mental health, we have actually a social worker that can help them not panic and not send people to the ER, because that's what we don't want to do.
Well, terrific. That was a great rounds. Really enjoyed it. Thank you.
Thank you.